Hi everybody, Deb reporting back from day 3, and this was basically an abstract session. So each speaker had 10 minutes to talk about the poster that they had, and this was about the thought of actually having prevention in RA and doing early treatment of different medications to see if there was any sort of prevention. So I'll tell you what the outcomes were, and there were 3 different studies. First one, long-term prevention of RA in high-risk, difficult-to-treat patients after a 6-month placebo or controlled, so 2 arms of the study, intervention with Orencia or abatacept. So the conclusions were, it was just more of a summary, that a 6-month treatment with Orencia strongly prevents RA during this actual use. And they said that the actual prevention was anywhere between 10 months to up to 5 years of delayed onset of actual RA. So in my idea, that sounds pretty good. Regardless of treatment, patients who developed RA earlier in the study had more pain, more inflammation, and really worse health-related quality of life and outcomes, and leads to that's more of a difficult to treat patient. But those are smaller numbers of patients overall. The next study is, do RA risk factors also affect the speed of clinical RA onset? It was a Swedish study, and the conclusions from this is, among individuals diagnosed with RA within 1 year from their first reported symptom, so the first thing that they started noticing, pain, inflammation, some of those type of things, was established. And they also looked at the risk factors like smoking and obesity and things like that would influence the onset of RA. They noticed that there was a lack of association of the risk factors to the speed of the onset of RA. So they didn't find much association in that, which I found interesting. And the ACPA and autoantibody profiles of those levels were not considered in this study. So they were just looking at the person at whole. They weren't looking at ACPA positive, ACPA negative, or any of those type of things. Third one is predicting the progression of interstitial lung disease in RA, a model developed from the clinical and serologic factors in a core rail cohort. So they were actually looking at a specific group of patients. And the conclusions were that they developed a quantitative prediction model for RA ILD progression based on RA specific and ILD specific factors, including key biomarkers. So those are the ones that they honed in on. The model stratified patients into low, moderate, and high risk groups with strong predictive performance. And I took note on the results of this. They were looking at the negative predictor value and a positive predictive value. The negative predictive value is low risk group, and the positive predictive value was 80% of the group was in the high risk group. They looked at this stratification model may support early therapeutic decisions for high-risk patients and help optimize monitoring strategies for low-risk patients in potentially improving cost effectiveness. So they were looking at the different value of treating the higher risk patients earlier and looking at possible improving cost effectiveness. So again, money matters, and I was glad that they looked into that piece for that. So those were just a touch of a couple of the abstracts, and they have abstract sessions where they report on those things, and wanted to give you a quick update on what those were that I saw and which one I thought would apply to you guys the most.